A very good evening, and respected ma'am and respected Dr. Radhakrishnan, sir. Thank you very much. Thanks for the privilege to moderate. I'm really grateful to you and express my deep gratitude to you for providing me this forum for moderating this particular session. Going to be an interesting session where my dear friends, all ICA members, all of you know that pain relief after surgery continues to be a major medical challenge. And you know that this poorly managed post-op pain may delay the recovery, may delay the discharge, and obviously it may lead on to patients, inability to participate in the rehab programs. I'm sure all of you will appreciate that. And this undertreatment of post-op pain continues as a considerable problem worldwide, I'm sure. There are different surveys and, like various surveys which have been done, especially in US in 1993, 2003, and then in 2012. They all show that post-op pain is common and remains undertreated. I'm sure you will agree with me. And that distribution and quality of the perceived pain have remained largely unchanged. And, even a European survey, which included more than 700 plus hospitals, they found that the management of pain, the post-op pain was suboptimal. That's very interesting because despite all possible best efforts, but somehow the post-op pain remains undertreated. And various reasons, you'll find the surveys have revealed the absence of documentation, absence of written protocols, and so on and so forth. And I don't want to bore you with that, but a recent survey, not a recent one, but at least in 2011, that's the latest one from NIH, which shows that at least 80% of patients were suffering from post-op pain in US and 50% were receiving inadequate pain relief. That means the remaining 50% received adequate pain relief. So this is where I would like to invite Dr. Jayashree Sood, who needs no introduction. She will be enlightening us on the pathogenesis, on the pathophysiology of acute postoperative pain and chronic persistent post-surgical pain. And all of you know that ma'am is heading the department. She's the chairman of the Department of Anesthesiology, Critical Care and Pain Medicine, the Perioperative Pain Medicine at Gangaram Hospital. And she has innumerable number of publications, so many books to her credit. And she has been examiner to various universities for MD and DNB examinations. And, she has been managing ICA like anything, and you have been seeing all those the WhatsApp groups which have been created, and so regularly she has been doing. So she has been, credit goes to her that she has been managing the department so well, such a big department at Gangaram Hospital. And at the same time, she is an international figure who has been to, different international forums in addition to all possible conferences, workshops, and seminars held in the country. And almost 2020, I would say, belongs to her because she has been managing all these webinars for ICA so well that I would rather appreciate a round of applause for Dr. Jayashree Sood. So Dr. Jayashree Sood, please, ma'am, I would like to invite you. Please enlighten us on the pathophysiology of acute postoperative pain and chronic persistent post-surgical pain. Dr. Jayashree Sood, please. Thank you, ma'am.
Thank you, Dr. Ashok, for those kind words. And truly, I don't know whether I'm really worth it. But anyway. Nemish, Sanish, could you mute everybody, please? Because
okay.
Sometimes there is a disturbance.
Okay.
Good evening, everybody. As Dr. Ashok has said about the post-operative pain, where the incidence is so high, it's very important for us anesthesiologists and the pain specialists who are looking after the pain, whether it is acute or chronic, it's important that we understand what is the pathophysiology behind it. Because if we do not understand that, then we will never be able to manage it. So pathophysiology understanding, which has changed so much over the years. As you keep on reading, it seems very, very complicated, but there's a huge amount of work that has been done and still goes on. No lecture on pain or any webinar on pain can be started without the definition of pain for the students especially. And see, way back in 1979, the International Association of the Study of Pain defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. But then last year, they were all thinking that we need to revise this definition and see what is the definition now given in July 2020. It says it's an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, with 6 keynotes and the etymology of the word pain for further valuable context. So it's not only just simple as that, but they're saying anything resembling that also has to be considered as pain. Now, when we talk about acute pain, it has been defined, in which, of course, the post-op pain also comes. It is a subjective sensation in response to objectifiable signals. It is the cyclical adjunct of a protective reflex. Yes, of course, pain, you may have the same surgery, but different patients, they express their pain in a subjective manner. So that, of course, plays a very important role. And of course, it has to be taken care of. So it is an easily identifiable event. Surgery has taken place. It's usually self-limiting, but treatment has to be given. It's a warning of ongoing damage, minimal psychological symptoms, usually nociceptive in nature, as we will see the pathophysiology. And if untreated, it's important, if acute pain is not treated, it may progress to chronic pain. However, chronic persistent postoperative pain has been defined as However, the International Association for the Study of Pain has defined chronic persistent postoperative pain, which is one part of our lecture. It says it is a clinical discomfort that lasts more than 2 months post-surgery without other causes of pain, such as chronic infection or any pain which could be from any condition preceding the surgery. So they say chronic persistent pain is that which lasts more than 2 months post-surgery. However, the International Classification of Diseases, that is ICD-11, they say this persistent post-op pain has a greater intensity or different pain characteristics than preoperative pain and is a continuum of acute post-op pain. The duration, in this, they say the duration is about at least 3 months post-surgery because healing times differ among So usually we always say that if it persists more than 3 months, it might go on into the chronic persistent pain. So when we talk about, we are talking about the pathophysiology, remember neurobiology of acute pain is the primary goal of acute pain pathways is to eliminate further pain. It has 3 levels: sensory, motivational, cognitive. Sensory is the discriminatory component, motivational is the affective component, and cognitive is the evaluative. All these 3 levels form the actual goal of the pain pathway. Now, when we talk about pain pathway, we all learned in our college days how the nerve endings are stimulated, how they pass on to the spinal cord, how they go on to the opposite side. However, there's much more to it. So these nociceptors or the free nerve endings are those that are present at the site of incision. They could be chemical, responding to chemical, mechanical, or stimuli. And these nociceptors or the free nerve endings that are present, they exhibit a high response threshold with a persistent discharge to supra-threshold stimuli without rapid adaptation, meaning thereby that these receptors respond to all these kinds of painful stimuli. And they are associated with small receptor fields and small afferent nerve fibers. Now, once these nociceptors are stimulated, they travel by the A delta, which is the thin myelinated, and the C polymodal fibers, and then they ultimately synapse in the dorsal horn, which we know about it. And then if you can see this diagram, which is very interesting, that once they come onto opposite side, that is the first order neuron, it synapses here in the dorsal horn, crosses to the opposite side, and then goes up that in the spinothalamic tract to be then relayed in the cortex. While this is the nociceptive pathway, which actually deals with how we react to pain, at the same time, they are anti-nociceptive pathways as well, which react and make sure that the surgical stimulus is removed or the pain that is felt is not so much felt. Now, if you see over here in this diagram, it's a very crowded diagram, but I wanted to tell you a few things here is that it is not as simple as that as they have shown here. So this is the sensory neurons and this is how it's going. And this area that we are talking about, these are the receptors which are coming here and this is the dorsal horn. And this is where everything takes place in what is known as peripheral sensitization. Now here, so if you see a patient who's had just an incision at the skin incision, what happens if you see the barrage of impulses they say are few. But if the stimulus is at the skin and the deep tissues, the barrage of impulses is much more, and that can then cause much more prolonged pain. So we call acute post-op pain as a pathophysiological state in which you have peripheral as well as central sensitization. That means peripheral means it's both due to inflammatory response and due to nerve injury. However, central sensitization, which takes place at the dorsal horn neurons, leads to plasticity or changes in the dorsal horn, which affect the modulation of pain. So this is a very interesting slide, which says that at what is peripheral sensitization. So at the nociceptor level, that is at the periphery, where they get stimulated because of the surgical trauma, you have tissue damage, you have inflammation, and you have sympathetic terminals, nerve terminals, where the nerves might get affected. And what they form is known as the sensitizing soup. Now look at this soup. It has hydrogen, ions, noradrenaline, bradykinin, histamine, potassium, prostaglandins, cytokines, substance P, leukotrienes, nerve growth factor, and neuropeptides. Here, what I'd like to emphasize is now this nerve growth factors is now having a lot of importance in peripheral sensitization. They say that this nerve growth factor is along with the other these things not the cytokines, but these mediators, along with this, it plays a very important role. And because of this soup, what that is formed, there is what is known as transduction sensitivity. That is the high threshold nociceptor, which would not respond, now becomes a low threshold nociceptor. And then you start feeling the pain. Now look at this again. It says the same thing, that this is the lesion. And this is where I said was all the release of potassium, bradykinin, and your substance P. Now what happens is this soup actually produces what is known as primary hyperalgesia. That is the area of the lesion or the surgical incision. Just surrounding that is what is known as primary hyperalgesia. Now, all these mediators, actually, they go alongside and release histamine from the mast cells, serotonin, platelets, and all this, what they form here now is this degradation of mast cells, and this is known as secondary hyperalgesia. That means now the normal area, which is adjacent to the area which was actually the one which had the skin incision, now it is a normal area which starts having the secondary hyperalgesia. These things are all very important because this is where we now will target our management so that the postoperative pain, the acute pain, does not progress into the chronic one. Now look at this. This is they've shown a diagram which says this is the incision, and surrounding the incision, you have the hyperalgesia. Okay? And much beyond that, there'll be no hyperalgesia. However, when we give drugs like ketamine or xylocaine, what happens is incision is here and this area of hyperalgesia decreases. And this is because of the understanding of the mechanism of action of these drugs. Now look here, this is where we were talking about the peripheral sensitization in details. So these are the nociceptors which are coming, and this is the dorsal horn. Now what happens is the main transmitter is glutamate, and this glutamate releases and acts. It is released from the nerve terminals and acts on what is known as the AMPA receptors. Now these AMPA receptors are very well known that they have a great contribution in the peripheral sensitization. Now what is this AMPA receptor? This is alpha amino 3-hydroxy 5-methyl 4-isoxazole propionic acid. These are the primary receptors for acute pain. Now if you see here, maybe you can see here better, these AMPA receptors are attached to the sodium and potassium channel, and this is when their sustained stimulation that takes place is that this prolonged AMPA receptor stimulation leads to priming of these NMDA receptors. See, they are adjacent. So once they are stimulated for a very long time, they now prime the NMDA. Now what happens once they prime the NMDA? This magnesium that you can see over here, which is blocking the calcium channel, the priming occurs and there is opening of the sodium and the calcium channels, and these NMDA receptors become susceptible to stimulation. So this whole thing becomes very, very complex. Now, another addition is, if you can appreciate here, these are those AMPA receptors here. Again, it is the same thing, glutamate, and you can see here is the dorsal horn. These are the AMPA receptors. And along with that, if you can see here, is the GLUR1 receptors, and these receptors are going side by side with the AMPA receptors, and they get phosphorylated with the SER831. And what happens is then this acts with the protein C kinase, only the gamma ones. And then ultimately what happens is they get stimulated and this circle takes place. So all this is very complex. However, these are the latest things that have come in the picture. So also you have what is known as the TRV, There are other receptors are also there, which are the TRV and receptors, and also the capsaicin receptors, which have been found. After having seen what is the peripheral sensitization, which acts at the receptor level, what is this known as central sensitization? This occurs at the level of the dorsal horn cells, where the nociceptor input, what does it do? There's an activity-dependent increase in the excitability of the dorsal horn neurons. So this activity that is taking place, it modifies the responsiveness, and the low threshold mechanoceptors are modified. And what happens is that those painful stimuli, which might have been not painful, now become painful. So these are the factors which might lead to the changing of into the chronic pain. There is another phenomenon known as the wind-up phenomena, which means again the same thing, primary hyperalgesia, secondary hyperalgesia, NMDA receptors being stimulated and leading to exaggeration of pain. So this chronic pain is shown again the same way, opening up. This is the NMDA receptors, which we said they were getting this thing stimulated, they were getting primed over here. And this calcium that is released over here from the NMDA receptors activates the protein C kinase. And then what happens is that this nitric oxide gets released from nitric oxide synthase and then diffuses back. And this sometimes produces opioid resistance, meaning thereby it has been seen that some patients who might have received a lot of opioid earlier, or they might have been taking opioid for some other reason, they turn out to have resistance to opioid, and they need to be given some either higher doses or some other alternative. And this nitric oxide stimulates the release of substance P, which binds to the NK1 receptors and triggers the CFOS gene expression. Now, this also leads to neural remodeling. Now, coming to this persistent post-surgical pain. So we have seen what is the peripheral, what is the central, and all that leads to neuromodulation. So this persistent post-surgical pain, which is a combination of your secondary sensitization, that peripheral central sensitization and modulation might lead to persistent post-surgical pain. It is a very complex phenomena, poorly understood, and it says it's probably maybe because of progressive proceedings involving biological, psychological, and socio-environmental factors. So a lot of genetic factors are being taken. Now here again, you can see here, this is the nerve growth factor that I was talking about, cytokines, and these are those TRPV1 receptors, and all these then act at this level over here. So the surgical lesion, peripheral sensitization acting at this level might cause central pain sensitization. So the nerve, I want to stress on the nerve growth factor and the cytokine release. So here again, it is trying to show why is it that some patients in the post-operative period, they recover so well, but some of them take a long time to, they develop the post-operative persistent pain. They say that initially, if the patient at the time of surgery has both the nociceptive pathway and the anti-nociceptive pathway equal and opposite, so they recover very fast and within a few weeks, they are back to normal. However, if there is a situation where the anti-nociceptive pathway is a little depressed, there is a disequilibrium due to any reason, this will take a longer time. And so also here they say there is a latent pain sensitization where it is further low and it may take longer. So all these factors are trying to show that what is your situation first in your pain pathway that might affect your recovery. So remember, what are the changes after incision? The initial nociceptive insult may sensitize individuals to a very long time. There are certain epigenetic changes. There may be an inability to recruit endogenous pain inhibitory systems, and you probably intensity of post-op pain, whether it is nerve injury or duration of surgery, might affect the development of the post-operative, persistent post-operative pain. So what are the conclusion and the future directions? Must remember that it is a complex bio-psychosocial phenomena, difficult to control or treat. You must limit the nociceptive input to reduce the nociceptive-induced pain sensitization and engage new therapies, multimodal of course, to reduce the risk of persistent postoperative pain. So to summarize, studies have indicated that different tissues have unique responses to incision, and this will hopefully improve our understanding about the pathophysiology of post-op pain and probably help us make our formulations to see that the patient does not develop the post-operative persistent. Thank you very much. Ashok, I'm finished with my lecture. Ashok, you have to unmute yourself. Dr. Pramod, unmute kar do. Sanish, please help them.
Ashok, aap hi kar do.
Yeah, that's right. Thank you so much, madam. I think for such an enlightening lecture, we will have discussion in the end. It is, you very rightly said that it is such, especially the persistent post-surgical pain is such a complex entity. And if I'm correct, they have enumerated more than 20 factors, including the pre-op factor, the intra-op, and the post-operative factors. And with the multiplicity of pathways involved in that, multiplicity of neurotransmitters involved in the genesis of that, you are absolutely perfect in saying that it is a complex entity which needs further research, and we'll have discussion in the end. Thank you so much, madam. Thank you. Wonderful. It's time for Dr. P. Kumar to kindly invite Dr. P. Jain, please. Dr. P. Kumar, please.
Next speaker is Dr. Pradeep Jain. We all know him very well. He is conducting a very good pain clinic in the Saragangaram Hospital, and he has been involved with Indian Society for the Study of Pain and ICA since a long time. He had been, in fact, helpful in starting this pain fellowship also through IAPM. Dr. Pradeep Jain will be speaking on recent trends in postoperative pain management. Dr. Pradeep Jain.
Thank you, sir, for the kind introduction, and good evening, everybody. My distinct topic is what is the recent trend in postoperative pain management and why postoperative pain management is important. Recently, in the last 2 or 3 decades, there's a lot many changes in the pain management, whether it is acute pain or chronic pain, and especially to decrease the morbidity and mortality, the lot of changes has taken place in this field. Like that, pain has been recognized as the 5th vital signs, pain relief as a basic human right. Global Day Against Pain is celebrated. There are guidelines and protocols almost by everybody. Ultrasound-guided acute pain relief has made this post-op pain relief much easier. There is advanced pain management techniques, new drugs have come up, and the establishment of acute pain service. Why we need to treat chronic post-operative pain? Because whenever there is an incision, there is a sympathetic stimulation, there is a stress response, which is neuroendocrine, there are metabolic changes, catabolism, negative protein balance, there is an organ system dysfunction, there is hyperglycemia, hypercoagulability, hyperalgesia or allodynia, immunosuppression, and psychological dysfunction. That's what Dr. Sood talks about the pathophysiology of postoperative pain. What are the goals of postoperative pain management? The goal of postoperative pain management is to provide continuous effective analgesia that is safe and free from unwanted side effects. And what we achieve out of it is the improved quality of life. It facilitates rapid recovery and return to full function, reduce morbidity, and allow early discharge from the hospital. Recently, in the 5 field, the changes, the advances have taken place in the postoperative pain management. Dr. Sood has already talked about the molecular mechanism, better understanding of the pathophysiology of postoperative pain. Pharmaceutical products have come up, routes and modes of delivery, novel modes of analgesia, and the organizational and the procedural aspect. So I'll be talking one by one about these things, except the molecular mechanism, which has been talked about Dr. Sood. Development and improvement of multiple intervention within the concept of fast-track surgery program represent the major challenge for the medical profession working together to achieve pain and risk-free perioperative case. So Dr. Kehlet in 2000, approximately 2000, he came out with the idea of multimodal strategies to decrease the morbidity and mortality in postoperative phase. And this leads to the multimodal analgesia or the balanced analgesia for postoperative pain management. And this has established itself as the gold standard of perioperative analgesic care. Multimodal analgesia is an approach to pain management that uses 2 or more drugs which act at different sites with different route to achieve the reduced doses, improve pain relief, reduce severity of adverse effect of the individual drugs. There is early discharge, it decreases the cost, and of course, it prevents post-operative persistent pain. What is the principle of formulating the analgesic plant? We must know, as already talked about the multimodal analgesia, post-operative pain has got one characteristic, that the pain decreases during the course of the time. Whereas in chronic cancer pain, it is the opposite direction. If it is not treatable, then the pain goes on increasing. So we have to come down with the step-down analgesic approach. There should be no analgesic gap if we really want to prevent the postoperative persistent pain, and the latter has to be followed. What are the new treatment modalities as far as the pharmacological and the non-pharmacological advances are concerned? Basically, in the opioid system, the new drug delivery systems have come up in the postoperative pain management. And the main innovation have been in the use of older drug in new delivery system and routes of administration. It is not that many drugs have come up, but the older drugs like opioids, etc., different opioids are now delivered in the novel modes of analgesia, like oral transmucosal fentanyl, intranasal fentanyl, sufentanil, dimorphine, ketamine, transdermal fentanyl, buprenorphine, iontophoretic delivery system, transpulmonary system, sublingual buprenorphine, sufentanil, extended release epidural morphine known as DEPODUR, and the liposomal local anesthetic. So we achieve, basically, it is the non-invasive approach. You give one injection and prevent the effect of the continuous epidural catheters, etc. Oral transmucosal fentanyl is generally used for pre-medication and for breakthrough pain in cancer pain and the postoperative pain. It provides an alternative means of delivering effective, rapid onset and non-invasive pain management in and out of hospital, combat or austere environment. The dose is 10 to 15 mics per kg. It is available as a fentanyl lollipop in 100, 200, 300, and 400 microgram. Intranasal administration. The advantage is it minimizes drug volume while maximizing the drug concentration. Ketorolac was approved in 2010 for the short term up to 5 days management of moderate to moderately severe pain in adult requiring opioid. And one spray is equal to 15.75 milligram, and one should not exceed 4 sprays. That means approximately 65 milligram of the ketorolac. Dimorphine powder in use in acute orthopedic trauma as taken nasally by the military people also in the war zone. And the butorphanol nasal spray came in the market. It was used basically by the private practitioner. Patient-controlled transpulmonary analgesia. It is an aerosolized liposomal encapsulated fentanyl form. It rapidly extends and personalized. You can titrate it, how much analgesia you burn according to your need. And those who are experiencing acute pain episode, and it is for the treatment of acute and breakthrough pain. Sublingual Sufentanil. It is a pre-programmed device. Each dose consists of sublingual sufentanil 15 milligram tablet. So the patient self-titrate to analgesia by varying the interval between doses, and minimum the time is 20 minutes. One can extend it as the requirement. One can, but only one can take the tablets after 20 minutes. The maximum recommended treatment duration is 72 hours. It is non-invasive, less cumbersome, and method of opioid delivery compared with IV route. So there's no IV route. It is give the same effect as the IV sufentanil. But the caution is there. Those who have severe hepatic or renal impairment, it should be taken very cautiously. Transdermal therapeutic system. The fentanyl comes in this system. It is a high potency, ease of administration. It makes a stable plasma concentration. Initially, it came as for chronic cancer pain management, but now we have seen like TKR is done and the thoracotomy patients are done who are sent home and they are still in pain. For so long-term treatment of postoperative pain, these patches, transdermal therapeutic systems are very, very good and they are very, very effective. And the patient doesn't have to stay in the hospital for a long time. But the disadvantage is that it is unable to respond to instant demand of the drug abuse. And buprenorphine patches are there, which can be used for 7 days. One patch lasts for 7 days. And the different concentration of 5, 10, and 20 milligram is available. Then another system that came is the fentanyl iontophoretic transdermal system. It is an innovative, needle-free, important. It is needle-free. There is no needle. It is just a transdermal patch, self-contained, pre-programmed drug delivery system that uses iontophoretic technology to deliver fentanyl through the skin by application of low-intensity electrical field. Pain relief as good as IV PCA. There is no catheter, no IV access required, and the patient mobility is not restricted. Then DEPODUR, extended release epidural morphine, approved in 2004 as a single-dose analgesic administered by epidural injection at the lumbar label. Morphine is encapsulated with liposomal delivery vehicle. The doses are 5, 10, 15, and the duration of action is up to 48 hours. The guidelines recommend periodic monitoring. The important thing about this DEPODUR use is that the guidelines recommend periodic monitoring for a minimum 42 post-operative period with increased monitoring for patients at high risk for respiratory depression. Now, opioids are the mainstay, no doubt about this part, but they have their own side effects. So traditionally, opioids have been the mainstay of post-operative pain management, but the opioid epidemic and the advances in multimodal and the enhanced recovery after surgery protocol have moved towards adjuvant modalities for treating postoperative pain. So to decrease the adverse effect of opioid, the people were trying to look for the alternative adjuvant analgesic, which were not primary analgesic, but they enhance the effect of the opioid and cause opioid sparing effect. So less dose of opioid can be used and get the better or the good quality of postoperative pain relief. So in this, the paramount importance came is the paracetamol. An intravenous formulation of acetaminophen was approved in 2010 for the management of fever, mild to moderate pain, or moderate to severe pain with the adjunctive opioid. It is an established component of now multimodal analgesia supported by several meta-analyses, and the adverse effect of paracetamol in therapeutic doses are negligible. This is the safest drug that is available in the armamentarium, pain management armamentarium for the post-op pain relief, because it can be used for the elderly, for the pediatric, the patient with the hepatic impairment in titrated dosage, or in the renal impairment. So if suppose, and it provides very good opioid sparing analgesic effect, like 40% of the opioid sparing analgesic effect is there. NSAIDs, a mainstay of post-op pain management, offsetting the inflammatory. The difference between paracetamol and NSAIDs is that the inflammatory NSAIDs have got the anti-inflammatory effect also. So the intensity of pain is less. And the IV formulation, now the IV formulation like ketorolac, diphenolic sodium, dexmedetomidine are all available. The transdermal patches are available. And when added to a multimodal regime, NSAIDs provide superior analgesia with opioid sparing effect and less side effect. Attempt to determine the safety profile of IV ibuprofen at induction of anesthesia, and this may be a viable option in the future. Emerging trend in pain management is back to the future is the focus on ketamine. Ketamine has been given a lot of focus regarding the pain management, and basically why it has been given focus is it has got the opioid sparing effect. It prevents the post-operative persistent pain. It is used for opioid induced tolerance and opioid induced hyperalgesia. And it is very good drug for prevention of hypersensitive wind-up phenomena, the allodynia. The low dose ketamine, like 0.1 milligram per kg per hour, potentiate the effect of morphine, ropivacaine, and epidural analgesia in the post-thoracotomy pain. The ketamine is effective by decreasing the pro-inflammatory cytokines formation, such as tumor necrosis factor and the interleukin. Oral ketamine may be on the horizon as a post-op pain management tool, but its safety and utility have yet to be determined. And it is an important option in the patient, those who are very difficult to treat, those who have very severe pain, and in spite of giving opioid, in spite of giving adjuvant, they still feel pain, then the ketamine is a very good adjuvant to be used for providing post-operative pain relief. Dexmedetomidine. It is a new, highly selective alpha-center 2 agonist, and the loading dose given is 1 mics per kg, followed by infusion of 0.2 to 0.7 mics per kg per hour infusion. The advantages, why it is commonly used, especially in the peripheral blocks also now, it has got a good analgesic effect, it provides titrable sedation, it is an anxiolytic also, and there is a low incidence of bradycardia and hypotension as compared to clonidine. It minimizes opioid-induced muscle rigidity, lessen post-operative shifting. And the meta-analysis of 14 studies, especially in the pediatric surgery, found it to be useful without significant side effect at doses of less than or equal to 0.5 mics per kg. Capsaicin. It acts as a TRPV1 agonist, and it's a receptor present on the unmyelinated C5 ending the periphery. The activation of TRPV receptors releases high-intensity impulses and release substance P, and subsequent, there's a decreased activation of the C fibers related to the pain relief. It is available as a cream, as an injectable also. And it is basically used for knee replacement as injectable, hip replacement, hernia repair, shoulder arthroscopy. Gabapentinoids. This is another, it was thought because secondary sensitization is just like a neuropathic pain. So probably if we can minimize the excitability of the nerves, then probably the incidence of post-operative persistent pain will decrease, the patient will feel less pain. And so the gabapentinoids were introduced as a preemptive analgesia, as a post-operative analgesic also for providing post-operative pain relief, because they reduce post-operative pain, they prevent development of chronic post-operative pain, reduce post-operative opioid use, reduce perioperative, especially anxiety. They are also very good anxiolytic agent. Improve perioperative sleep management also. And routine use of gabapentinoid for post-treatment cannot be recommended, but it has been found that the advantage of getting opioid-sparing effect like 6 milligram of morphine, if you are using 2 or 3 days the pregabalin, but the said advantage of the side effects are too much to get the advantage of using this gabapentinoid. So a systemic review of 11 randomized controlled trial showed that gabapentin decreases the incidence of post-operative persistent pain, whereas a more recent Cochrane review and meta-analysis dispute this. So there is a lot of controversy now whether the gabapentinoids, but I think where the nerve damage chances are more, then the gabapentinoid as a preemptive analgesic are a good choice for post-operative pain relief and opioid sparing effect. Then magnesium. It receives attention as a possible perioperative analgesic. Magnesium antagonizes the NMD receptor and block calcium channels to modulate pain by preventing central sensitization and inflammatory response. It is beneficial for multimodal pain management. The loading dose of 30 milligram per kg, 30 to 50 milligram per kg, followed by a maintenance dose of 6 to 20 milligram per kg until the end of the surgery. But people are now using this magnesium as a opioid sparing effect and adjuvant analgesic also. Lignocaine, several meta-analyses, intravenous lignocaine infusion is associated with many benefit in abdominal surgery. This lignocaine has been, because it is used to stabilize, it is a membrane stabilizer. So probably the excitability phenomenon can be checked by using the IV lignocaine. And it is used in the chronic pain in CRPH, etc. So the post-operative pain relief, and it has been found to be useful in basically abdominal surgery. And a systemic review of analysis of 45 trials did find effect of IV lignocaine on reducing post-operative pain. However, the evidence was limited in quality. So some people are using IV lignocaine for providing this post-operative pain relief. Then the non-opioid patches are available, like new patch, this arthro patch, and dichrotic patches are there. Regional anesthesia techniques then comes. The epidural technique is gold standard no more. So basically, what used to be the gold standard, this regional technique for providing pain relief for thoracotomy and the major operation is the no standard technique, not the gold standard technique. Local anesthetic based infrared technique as a first line component of multimodal analgesia. Perineal technique effective, but they are underused. And the local infiltration analgesia is a game changer in orthopedic practice. Local anesthesia infiltrative technique is growing and evolving the way forward. Focus on the role of simple local anesthesia-based infiltrative technique as a primary component of multimodal analgesia. Wound infiltration, preperitoneal, intraperitoneal administration, transabdominal tab block, and local infiltration analgesia as a single administration or with catheter place. This is the technique of choice and the first choice of multimodal analgesia as the regional techniques are concerned. Perineal techniques, effective, but they are still not being used as a very common reagent, but they're very highly effective and superior to intravenous opioid technique. They are recommended as the first choice of for major or for orthopedic surgical procedure, such as hip or knee replacement. Several meta-analyses concluded the peripheral blocks such as femoral and the sciatic are superior to epidural analgesia for knee replacement, and there is no effect like systemic effect, which are feared for the epidural, like hypotension, unitension, and or other complications. Surgical side effect perineal techniques are being commonly used nowadays. Whether it is the brachial plexus block, the knee injection, or in the sciaticofemoral block, these are continuous techniques are being used. Then the patient-controlled regional analgesia, where patient may suffer intense pain following single injection after 12 to 24 hours. So the patient-controlled regional analgesia by catheter extend the duration of post-operative analgesia beyond the finite period. And that is a significant advantage of postoperative sustained analgesia, opioid sparing effect, less sleep disturbances, and improved rehabilitation. The liposomal bupivacaine has come up, and it is a multiple lipid layer surrounding bupivacaine, thus allowing for liposomal bupivacaine diffuses up to 72 hours. So single injection of liposomal bupivacaine will be effective for 72 hours. And there is a currently limited insight whether this should be used for the peripheral nerve block or not. And the common concerns are, which has been now no more there, because it can cause cardiotoxicity, it can interfere with the wound healing, and it can cause erythema at the local site node, which has not been found. So another thing that changes the post-op pain management the recent year has been various guidelines. Where guidelines have come up from the American Society of Regional Anesthesia, from the American Society of Anesthesiologists, and then and we in our country also, the ISA, ICA, Indian Society of Study of Pain, has also come out with the various guidelines. This American Society of Guidelines that is prepared by the approximately 23 specialists, and they have come out with a 32 recommendation. This thing I'll not go in detail, but basically the very strong recommendation with high quality evidences are the use of multimodal analgesia, use of acetaminophen or NSAID as part of multimodal analgesia, in which there is no contraindication, surgical site-specific peripheral regional techniques, and the neuroaxial analgesia for major thoracic and abdominal surgery. Then the moderate quality evidence is they want avoid the intramuscular route, choosing IV PCA where the parenteral route is needed, and avoiding basal infusion in the opioid naive patient, and the preoperative oral celecoxib without contraindication. Then, of course, interpleural anesthesia not to be used now for the thoracic surgery, and avoiding the neuroaxial administration of magnesium, benzodiazepine, neostigmine, tramadol, and ketamine of not much use. Then about the patient education, preoperative evaluation, etc. In ICA, Dr. Ashok Saxena also came out in 2016 with the acute pain management guidelines and protocols in detail. Then there's a guidelines about the acute pain management, very good book by the Australian New Zealand College of Anesthesiologists, which has got the scientific evidence, acute pain management and the post-op pain management according to the scientific evidence. Then procedure-specific post-operative pain management has come up, because it is not a one-size-fits-all modality for every patient. Because the emphasis is now on the personalized post-operative pain management techniques. Because pain intensity, why procedure-specific post-operative pain management? Pain intensity and tissue trauma are procedure-related. There is a risk-benefit ratio of different analgesic with different type and site of surgical procedure. The stress response and organ dysfunction differ in different surgeries, and it helps selection of analgesia and to avoid side effects. So this is about the different types of surgery where the procedure-specific guidelines are there. Then another aspect that has changed the scenario of post-op pain management is the role of the acute pain service. It provides adequate post-operative the acute pain service is very, very important to provide good post-operative analgesia, improve quality of analgesia, efficacy, train anesthesiology residents, clinical research, and the anesthesiologist's new role in the care of the surgical patient. From various studies, it has become evident that the solution of inadequate pain relief lies not so much in developing newer technique, but more in the development of formal organization for better application of existing knowledge and techniques like APS, acute pain service, which is dedicated to the management of acute pain. So we must utilize the techniques. We must organize. We must have acute pain service organization if we want to improve the post-op pain management control. Then the genetic aspect, genetic polymorphism are known to affect pain sensitivity and analgesic response, and this specialty is bound to come where the post-op pain management will be individualized according to the genetic susceptibility of the patient, or what is the tolerability of the patient towards pain. Then there is an enhanced recovery after surgery, fast-track surgery. Post-operative pain management should be considered as a package including analgesia with local anesthesia as a part of multimodal approach, early instignation of enteral nutrition, early mobilization, close supervision of fluid balance, and close attention to the cardiorespiratory function to accelerate post-operative recovery and decrease length stay. So in conclusion, opioid remains the mainstay. Multimodal anesthesia is an essential component. Regional technique, very effective. The epidural is not the gold standard now. The paravertebral technique should be used. Peritoneal technique are good alternative, and infrared techniques without catheter are useful. Enhanced recovery after surgery protocols are becoming the benchmark standard for enhancing postoperative recovery. Recent renewal of interest in the adjunct in the post pain management. Among opioids, sublingual sufentanil, oxycodone, and the anti-Transdermal system hold promise, and the extended role of acute pain service may emerge as a potential area of importance, and the genetically informed personalized medicine may become a reality. Thank you very much for this thing.
Thank you, Dr. Pradeep Jain. Hello.
Yes, sir. Yes, sir. Thank you very much.
You have really in detail discussed the various trends, like first thing was pain as a fifth vital sign, a global day, all these achievements, various mechanisms. So everything was involved towards the early recovery of the patient, and especially a multimodal approach which you have advised. Nowadays, it is very important so that we can plan a formulating anesthesia plan with various routes, because now there are so many routes, so many drugs are available which have their own use, their own mechanism of action and simplicity as per their need and their various routes. The clinical experience with various drugs have allowed us to know about their limitation and side effects in a better way as per the intravenous or their regional anesthesia techniques, especially epidural, USG like TAP block you discussed, PNB, various international guidelines. They are also stressing upon the various approach, the genetic approach, the APS, ERAS, and especially the word is personalized care with procedural specific post-operative analgesia. You have covered everything in detail. Thank you very much, Dr. Pradeep Jain.
Thank you very much, sir.
Now, I will invite our third speaker, Dr. Puneet Mehta.
Thank you, sir.
He's speaking in ultrasound in acute pain, post-operative pain management. Dr. Mehta, please.
Thank you, sir. I hope my screen is visible.
Yes, it is visible.
Okay. So I would start by thanking the organizers, Dr. Jayashree and Dr. Pradeep Jain and the whole ICA team. And just to continue with the talk, I would be shifting more towards the clinical side. As we are all aware that the post-op pain has multiple implications, which is concerned to the outcome of the patient. It is also concerned to the resource utilization of the hospital, as well as it has some specific effects like cancer recurrence and persistent post-operative pain. So the rationale of using ultrasound guided regional anesthesia for managing the post-op pain basically helps us to decrease the dependence on the opioids, hasten the recovery of the patient, and minimize the resource utilization of the hospital. And because of the easy availability of ultrasound in the regional anesthesia practice, it has kind of helped us to understand more about the blocks which we were using anyway initially. So, we have all come across from that stage where it was a landmark based technique and there was always a hesitancy to rely on the regional because there was always an element of unsurety related to the regional anesthesia. But now the learning curve doesn't seem to be that long, and people who start using it, they become very familiar with the anatomy and with the techniques, and from from a general anesthesia or regional anesthesia. Now regional anesthesia, as mentioned by the previous speakers, it has become part of the multimodal analgesia. So we are combining as much possible of regional anesthesia with the general anesthesia now to take care of both the intra-op decrease in the opioid requirement as well as to ease the post-op pain management. So there was a nice...
Sorry to interrupt. Can you go to the slideshow mode, Dr. Puneet?
Okay, just a second. Is it better now?
Yeah, it is better.
So there was a recent narrative by Dr. Chin where he summarized the benefits of acute pain, of regional anesthesia, which go beyond the acute pain, as I mentioned in the previous slide, that it helps in both the patient outcome as well as the hospital resource utilization and the economic benefits. As mentioned also by Dr. Pradeep Jain, there was this post-operative pain clinical guidelines by the American Pain Society in 2016. So they have recommended some, alternatives of regional anesthesia techniques, which can be, which are site-specific, which can be used for the pain management, like for thoracotomy. Paravertebral blocks have become the first choice. Now we have evolved further because of the risk of the pleural puncture and the pneumothorax. We have again evolved to giving erector spinae block instead of the paravertebral blocks, because we move away more from the pleura and from the epidural or from the centroneural axis structures. Similarly, for the open laparotomy, they have advised strongly for the transverse abdominal plane block, or the TAP block that we frequently know of, which again we have evolved from the TAP block to the posterior TAP to the quadratus lumborum block, or to further modifications of quadratus lumborum also. For the joint replacement surgeries like the total hip replacement, they have advised for the site-specific regional anesthesia techniques like the femoral nerve block, the adductor canal block, the fascia iliaca compartment block. For the similarly for the hip replacement as well. For the spine fusion surgeries and for the patients who are sick, who have to go procedures like kyphoplasty or vertebroplasty, there even the blocks like the paraspinal, erector spinal blocks, they help by reducing the opioid consumption by blocking the dorsal rami of the spinal nerve. So there they have really come to of help. Similarly, for the cesarean sections, they've advised for the transverse abdominal plane block, which now further has evolved to the quadratus lumborum block. So over the last 20 years, since the ultrasound has come into the practice of regional anesthesia, more and more understanding about the anatomy and the functional, the utility of these blocks has created further, a new kind of facial plane blocks as we see coming every day, and trying to make it more safe for the patient and more easier for the anesthesiologist to practice them in as much as possible ways. So this presentation is, I think, too short to cover everything as far as the ultrasound guided regional anesthesia is related. So I would be rather just clinically touching the blocks, various blocks which are involved for various types of surgeries. Can't go into too much of the details in this short time, but I hope we are open to questions, and whatever clinical day-to-day queries are there regarding to any particular block can be discussed at the end of the session. So for the upper limb blocks, we have options of the superficial. So for any region that you're covering for the regional anesthesia, one has to be clear about the tailoring of the region where you need to block. So the anatomy of the region, the site-specific region, helps us to decide which block will suit you the best for a particular surgery. So if you talk about the superficial cervical plexus block, then anything like a chemoport insertion or a trauma of the clavicle, the superficial cervical plexus block helps. So for a superficial cervical plexus block, the landmark that you would want to see on an ultrasound picture is that you would keep your ultrasound probe in a transverse position over the sternocleidomastoid, and as you move posteriorly, where you can see the posterolateral margin of the sternocleidomastoid, you can see the facial plane where the superficial cervical plexus is located, and just beneath this facial plane is your interscalene level, where you can see the 3 trunks of the interscalene block. So if you are, targeting somebody who's coming for an ambulatory surgery for a chemoport, and you want a good, easy recovery where minimum of opioid is used, then this block comes into help. Similarly, this block also helps when you are, somebody is having a thyroid surgery and you want a minimum requirement of opioid, or you want to decrease the opioid requirement, there this blocks helps. So you just give 10 ml of local anesthetic behind the posterolateral margin of the sternocleidomastoid muscle, and that's how you achieve this block. Then coming to the interscalene block, this block is basically targeting for the upper arm surgery and for the clavicle surgery. So this block combined with the superficial cervical plexus block helps to cover both the trauma of the upper limb as well as the clavicular trauma. So sometimes there's an identification problem of the trunks of the interscalene block which are done. There is a problem in identification. Then you can use the traceback technique where you put the probe in the supraclavicular window and trace back upwards in the neck. So that way, most of the time you are able to visualize the trunks between the two, the anterior scalene muscle and the middle scalene muscle. Now, the other advantage of doing this block with the help of the ultrasound identification is that from the conventional volume of the local anesthetic that we used to give, which was around 15 to 20 ml, now we can come down to 5 ml of local anesthetic, which you can see on ultrasound to cover all the three trunks when you give this block. And with the with the less volume of the drug, the chances of your prevention of the phrenic nerve blockade are also decreased. Another thing which one needs to kind of take care when doing this block is to always go from the lateral to the medial side when you are needling, as shown in this picture, so as to avoid the injury to the phrenic nerve, because that lies more on the anterior scalene muscle, on the anterior surface of the anterior scalene muscle. So the needling technique is important, the identification of the structures is important, and the volume of the drug reduction also helps in the prevention of complications, especially if you're dealing with a patient who has a pre-existing COPD, where you would not want to the phrenic nerve to be involved. Then also the advantage is that sometimes there are anatomical variations in the C5 and C6 roots, wherein the C5 would be lying in the anterior scalene muscle. So there, if you see a neural structure which is lying embedded in the anterior scalene muscle, then blocking separately that would help. Otherwise, if you are going for a shoulder surgery patient and that upper trunk is spared, then that would lead to less of analgesia in that region, and your probably block would be a patchy block. The other challenge which one faces while giving this block is that if you give a local anesthetic alone, then the duration of the block is not that long, so it doesn't not last more than 6 to 7 hours. So there, the adjuvants like dexamethasone, dexmedetomidine, clonidine, all these come to your rescue, as mentioned by Dr. Pradeep also. So here again, drugs like dexamethasone do have a debatable utility because they are off-label uses of these drugs, and they are studies which talk about perineural toxicity with dexamethasone. But of whatever literature that we have, doses from 1 to 4 milligram have been found to be less associated with the neural toxicity as compared to higher doses of dexamethasone, which some people were using in the initial phases, like 8 milligram to 16 milligram. But now with the recent literature, up till 4 milligram has not been associated with too many complications associated with it. Similarly, the other side effects which one can encounter with dexmedetomidine is that you should anticipate some kind of hypotension or bradycardia, especially if your patients are already on some kind of beta blockers or drugs which have a propensity to decrease the heart rate. So one needs to be watchful or kind of anticipating that issue, and vis-a-vis dexmedetomidine has to be used or not has to be used, has to be taken into consideration. So this is just a sonoanatomy picture wherein you can see the anterior scalene muscle on the medial side and the middle scalene muscle on the lateral side, and in between you can see the three trunks of the brachial plexus. And this is a small video. I don't know how much is it of use on this platform to be understood. Here you can see the needling coming from this side, And I'm trying to also show the trace down. So when I come from the top to the bottom, I come to the suprascapular subclavian artery here. And so this is what I was talking, when you can't identify, you trace it back, or when you are coming from the top, you can come down and identify, be sure of that you are seeing the trunks and not any neural structure. Then if you are targeting a surgery where you are, going to deal with an elbow or a forearm surgery, then infraclavicular block is a good option. The only hindrance for, the starters is that, it's a slightly deeper block compared to the block that you give for the interscalene or for the supraclavicular block. Because here you have to cross the pectoral muscles, and you are you are needling close to the pleura. But because the position, as you can see in the picture, you keep the probe in a parasagittal position medial to the coracoid process, and you go in line with your needle. So you can see the entire needle in your penetration when you are targeting. So this is the needle which is going towards the cords here. So the identifying structure here is the axillary artery, and you can also see the axillary vein. So you start from the top, cross the pectoral muscles, and come to the posterior border of the axillary artery. So if your needle tip is near the posterior cord and you give the drug here, and you can see a U-shaped distribution of the drug, then you are sure that your infraclavicular block is going to work. Sometimes on the medial side, the medial cord is spared. For that, you can do your needling. You can change the trajectory of needle again and come between the axillary artery and the vein, and target the medial cord separately. So that completes the 3 cords covering. And the biggest advantage that one finds while doing this block is that the continuous catheter is the best suited for this block, because your catheter kind of gets a good grip when it tunnels through the muscles. Whereas that becomes a limitation most of the time when you're doing an interscalene block, because the catheter length which is inside is very small. It's hardly 2 centimeters or less than that. And most of the time you encounter a dislodgement or a leakage with the interscalene catheters. So for that also one can do the tunneling, but then neck is such a vascular structure, and most of the time you'll find an external jugular popping in your way. It most of the time creates a problem. So in that way, infraclavicular block does have an advantage. The other thing which, in the upper limb is of help with the use of the ultrasound is the rescue blocks, which you can specially use for patients wherein, somebody coming to the ER with acute pain, and you want to target a specific region. Or if somebody is coming for an AV fistula surgery in an ambulatory setup or a daycare mode where you don't want to block the whole limb, then you can just give a individual nerve block like a median nerve at the elbow, and that suffices for your AV fistula surgery at the elbow. So sometimes you may have a patchy block with any of the brachial plexus like interscalene or axillary. Then also, depending upon your identification of the deficient area, you can use the rescue block and block individual nerves at the elbow or lower down, where if depending upon the access to the region that you have. Coming to the lower limb blocks, again, depending upon the site specific, what you're targeting, you can use the femoral nerve block, adductor canal block, sciatic nerve block, and the fascia iliaca block. So the common surgeries that you would kind of encounter are the knee replacement and the hip replacement surgery, and patients coming for the hip fracture surgeries. Now, again, here, if you are doing a femoral nerve block, the identifying structure would be the femoral artery by keeping the probe in a transverse position on the inguinal crease. And the femoral nerve is, seen lateral to the femoral artery, as we know from our anatomy, knowledge of the anatomy. So the target is to just be close to the femoral nerve by passing through the fascia iliaca and depositing the drug here. So you can see a good spread of your local anesthetic around the femoral nerve. So anybody coming for a femur surgery, a quadriceps surgery, or you need analgesia for the hip. Now the biggest advantage that we find for this block in patients coming with the hip fracture is that these patients find it very difficult to sit, especially if you want to make somebody sit for giving a spinal injection. there, instead of, giving a good dose of opioid, if you give a femoral block, single shot femoral block in the supine position, that makes a patient quite comfortable to sit up, and you can easily give a spinal with the help of giving a spinal femoral block. Similarly, fascia iliaca block is an extension of your femoral nerve block again, in the sense that, here, instead of going close to the femoral nerve, you are just entering the fascia iliaca and you are lateral from the femoral nerve. So but the advantage of giving the fascia iliaca block is that you are also covering the lateral femoral cutaneous nerve of the thigh, which covers the lateral aspect of the thigh. Whereas with the femoral nerve, you are just covering the anterior and the medial side of the thigh. With this, you can get a coverage of the lateral area also. Then the adductor canal block. This has again evolved from the limitation of the femoral nerve block, where because the femoral nerve block gives you the motor blockage, and the surgeons would always complain that, we don't want the motor blockade on the first post-op day, because we want to make the patients ambulatory. So this block gives the advantage that, it spares that muscular blockage which you get with the femoral nerve block. And the trick while doing this block is that you give this block is done at the middle part of the thigh, and again the targeting structure is the femoral artery, on the lateral side of which you see the femoral nerve, the saphenous nerve, which is a branch of the femoral nerve. The trick is that you give it as distal as possible, because if you give it a little proximal, then there is chance that the nerve to vastus medialis is also blocked, and your advantage of giving the adductor canal block is lost. So you give it as distal as much as possible in the thigh, so as to spare this nerve. And again, the volume can be, reduced, or you can put a continuous catheter by giving initial less volume and then putting the patient on a continuous drug infusion, so as to take care of the pain. Then the sciatic nerve block again can be given anywhere from the gluteal region, the classical sciatic nerve block, to the subgluteal approach, to the popliteal sciatic block, depending upon the utility where you need. So in this picture, you can see the classical area approach, where you give the gluteal approach to the sciatic nerve block. Again, the identifying structures are the ischial tuberosity on the medial side, and the greater trochanter of the femur on the lateral side, and the gluteus maximus on the anterior side, and quadratus femoris on the lower side. So this sciatic nerve can be seen on the posterior side of the gluteus maximus. So this is good for any hip surgery. But again, here the major limitation is the depth at which you can see the sciatic nerve, and so the identification becomes a problem. So doing it at a subgluteal level, you can see the sciatic nerve at a more superficial level, and it serves the same purpose. Similarly, if you have to, somebody has to undergo a surgery for a below knee surgery, then the popliteal sciatic nerve block helps. It covers the whole lower leg, both the motor and the sensory component, except on the medial side, which is covered by the saphenous nerve. So here, again, the identifying structures are the popliteal artery and the popliteal vein. The nerves, they are located on the lateral side of the vessels. Again, at the time of injection, one has to be sure that you are covering both the branches of the sciatic nerve, that is the tibial nerve as well as the common perineal nerve. Otherwise, chances are that you might have a patchy block. And again, this is a very good site for giving a continuous catheter block, wherein you can have a prolonged analgesia with the help of your catheter, and is best suited for patients undergoing below knee amputation, or patients coming for diabetic foot which needs some kind of debridement, or coming for multiple admissions. There you can just put a catheter, and that catheter can be used every time the patient comes to the OT. There are various ways and you can go about giving the block. Like this, in this picture, you can see that it's being given in the prone position, whereas in this, it is being given in the from the lateral approach. So depending upon the accessibility that you have in the patient, you have to decide the way in which you want to go about the block. again, with the ultrasound, as I told initially, the facial plane blocks have, really added a lot of options to our regional anesthesia techniques. The first one is the PEX block. This was developed by Blanco for the breast surgeries. So initially we had the PEX-1 block where we were targeting the lateral and the medial pectoral nerve. The identifying structures on the ultrasound being the pectoralis major and the pectoralis minor muscle. And in between the two muscles, the major and the minor, we would deposit the drug, and that makes it, that covers the PEX-1. Whereas for the PEX-2, you move laterally and posteriorly, and you try to see the serratus anterior muscle as well. So the target structure here, the facial plane here, is between the pectoralis minor and the serratus anterior. So this covers more of the infralateral chest, especially the axilla, and this can be of use in patients coming with thoracic trauma, as it also covers the intercostal nerve branches in this. Then the tab block. The tab block is, covering the anterior and the lateral abdominal wall. Here, again, the target structures can be, decided based upon where your incision in the abdomen is. So if you are, going for an upper abdominal surgery, there you can use the subcostal tab, which targets the T6 to T9 abdominal nerves. If you are, going for a loin surgery, for a loin incision, then you can go for the posterior tab. Depending upon the region which you want to cover, you can modify your tab according to the area. They have been named as the subcostal tab, the posterior tab, or the lateral and the anterior tab. So in this video, I'm just trying to show that my needle is inserting between the internal oblique and the transverse abdominal, and with the drug, the transverse abdominis is going down and the internal oblique is pushing up. Then erector spinae block. This has been, this was initially described as a block for thoracic analgesia for all the chronic pain patients, but it was eventually described by Forero in 2016, I think, for the breast surgery, wherein it was used for the analgesia for the breast surgery. It was used at the T5, T6 level. The identifying structure here is the transverse process in the paraspinal position. So the main advantage being over a paravertebral block is that you stay away from the pleura and you stay away from the central neural axis, and you deposit the drug just below the erector spinae muscle on the top of the transverse process. So if one kind of regularly uses this block, one also gets an idea of how to go about the thoracic epidural. Sometimes putting a thoracic epidural is quite tricky in patients. So by doing a scout scanning, because of having a prior knowledge of doing this block, one can also use this block to have a knowledge of the thoracic anatomy if one gets stuck up in a thoracic epidural block. So as you can see in this video, I'm showing the transverse process. You can see the pleura down here with the respiration.
You lost.
Sorry, sir.
Please continue.
Okay. So as the drug is being deposited here, you can see the erector spinae muscle getting lifted, and you can see a hypoechoic black area coming into picture, which is the drug which is being coming into the picture. So because this is an out of plane technique, you can't see the needle, but you can see this drug spread which has come over the transverse process. Again, paravertebral blocks, they came more in use before the erector spinae, and again, the identifying structures here are the transverse processes, the pleura, and the superior collateral ligament, which form the boundaries of this space. Now, again, the paravertebral blocks can be used to suit the level that you want to block. The main concern was always been the pneumothorax. So we use this block mostly for the thoracic surgeries, wherein you always have that surety that, the chest tube would be there on your side. And since these blocks have come into this thing use, we've stopped using thoracic epidurals and we rely more on the thoracic paravertebral or the thoracic erector spinae blocks. And compared to the erector spinae, we still find thoracic paravertebrals working better in terms of post-op pain control that you have from the patient feedback. And this is a good site for catheter insertion as well. The other advantage that you have with the paravertebral, thoracic paravertebral, is that there are less chances of hypotension compared to a thoracic epidural when you give a unilateral paravertebral block. And also it does, if you do it before the surgery, less and less chance of chronic post-surgical pain, as has been talked in all the literature before. The quadratus lumborum block came as a modification of posterior QL block based on the understanding of the extent of the thoracolumbar fascia with the dye studies which have been done in the cadavers. And it was found that depending upon the area where you approach the quadratus lumborum, the spread of the dye was different. So it was found when you do a transmuscular quadratus lumborum block, where the target is that your needle tip is in the interior margin of the quadratus lumborum and your psoas major, there the spread of the dye was the maximum, going up to the lower thoracic paravertebral spaces. So that formed the basis of using QL3 or the anterior quadratus lumborum that we call it. So again, here the identifying structures are that you try to identify the lumbar transverse process by keeping the probe just above the anterior superior iliac spine in a longitudinal position, in the transverse position, and you try to identify the the quadratus lumborum muscle here, and posterior to that you can see the psoas major muscle. So when you do the needling from this side, you target to reach between the facial plane between the QL and the psoas major. So the other application that you can use with the same approach is that if you want to give a lumbar plexus block, then instead of stopping short of the plane here between the QL and the psoas major, you can go further down into the psoas major. And if you're using a nerve stimulator, you can easily target the lumbar plexus block as well. So this block has found its application in surgeries like cesarean section, hip surgeries, and patients where you can't use neuroaxial techniques, patients having coagulation disorders because of sepsis, or patients being on therapeutic doses of low molecular weight heparin. Therein, these blocks really come useful. Then, when you encounter a spine like this, and you want to have an idea of, where the center of the spine is, or, where you should approach, then we in these kind of patients, we use a longitudinal probe, that is the low frequency probe, and do a scout scanning by keeping the probe first in the position, as you can see, between the two interspinal spaces. And you can, this is a picture that you get when you put the probe in the transverse position. You can identify the spinous transverse processes. And sometimes in thin patients, the posterior ligament and posterior complex and the anterior complex, which includes your anterior complex, includes the dura and the ligamentum flavum, which you cannot see on your ultrasound as separate, but you can see a complex here. So a scout scanning does help you in identifying your midline and going about your difficult spinals. Similarly, you can have another view, which is the parasagittal oblique view, wherein you can put your probe in the parasagittal position, and you can identify your articular process and your facet joints. This comes more handy when you are doing a chronic pain block like a facet joint pain, or you are trying to some people try to do the under vision spinal block, which is not that which is quite debatable because of the type of needles you need for it, the sepsis, the sterility concerns and all that. But yes, a scout scan does help to identify the body to find your trajectory. Similarly, giving a caudal block blindly in children, always a person is in doubt by the pop sensation one has while giving the block. But if you use a linear probe in a child in a transverse position over the sacral cordon, as you can see in this picture, you can easily identify the sacral cornu and the ligament in between. And you can even do a scout scan and do the, be sure that your needle is going to the right plane compared to doing a blind block. You can even see the drug spread to be sure that you're in the right plane. Then, as I talked earlier, the limitation of the duration of the peripheral nerve blocks can be, taken care of by the adjuvants, wherein there are options also like buprenorphine, which give a duration of around 9 hours with the single shot blocks. But yes, they do come with a lot of side effects like nausea and vomiting. So they are not that popular as an adjunct, and mostly it is the dexamethasone which is being used as it gives around 8 hours of duration of the block. So lastly, I would say these are kind of thumb rules which anybody practicing anesthesia should practice, is that knowing the anatomy, planning your tailoring your need for the block, and plan for acute pain management for each patient with the risk benefit involve the patient in the decision making. And also one should follow up the patient beyond the recovery room, because sometimes patients do have unanticipated complications or problems which one only knows when one follows in the post-op. Otherwise, you hardly hear about the complications, and we just be complacent that our block worked very well and there was no problem. Again, if you are putting a patient on a continuous nerve infusion, then the drug infusion should be properly labeled and color coded so that the sisters don't accidentally connect those local anesthetic infusions into IVs, or there are any accidents related to local anesthesia. Thank you, everybody. And
thank you, Dr. Puneet Mehta. Initially, USG started for locating the peripheral nerve blocks. Later on, we started giving information. Now, with tab block, their advantages, so techniques. So now you can say that this, with time, it has become, there is an expertise in various techniques which are more safe. This USG guided pain relief has become almost a subject in it itself now. Although we were using it before also for in physiotherapists, they were using it for back pain and other acute and chronic conditions. But now, this very much useful, these techniques which we were using previously, they are more safe because of use. As you have discussed such a wide subject in a very short period. Thank you very much, Dr. Puneet.
thank you, sir.
Now I invite my colleague, Dr. Ashok Saxena, to conduct this question and answer session.
Well, yes, thank you so much, sir, and thanks very much indeed for enlightening lectures by all our three learned speakers. It's my turn now to invite questions. Any comments, any suggestions from the participants of this webinar? So there was little bit of chatting. Yes, we could reply to one or two of chats, but then yes, any questions, please?
Okay.
Yeah.
Hello. Sure.
Yeah. Yes, sir. Yes, sir.
I have a question.
Yes, sir. Please.
It may be a bit premature, the question, but the question is open to all the faculty members. Why do you want these days multi-modal therapy than a single model management of pain? Because earlier we were believing, well, we go with local anesthetic or we go with drug. Now we go with a multi-modal and again with a multi-modal. Well, when we use the pharma, we combine many pharma. And why this particular state has come? Can anybody give me a convincing explanation?
I will. Thank you, sir. Thank you for an interesting question. Very valid question. I would be inviting Dr. Pradeep Jain first. Dr. Pradeep Jain.
Basically, sir, the approach to pain management, if you are using a single drug, an isolated drug, then you are using it in a large quantity. And every drug, there is not yet been developed which has no side effect. except paracetamol is the one drug which is comparatively closer to that level. So if you're using on opioids are very, very important ingredient for providing severe postoperative pain relief, where the pain relief is severe. And if the opioid are used in large quantities, then the side effects are there, which may make cause the benefit observed with it. So it was thought that if we can use opioid also, but in less quantity, less amount, and get the summation effect with other drugs which are not primarily analgesic, but when combined with opioid, they produce superior analgesia in combination. It is just like making 1 + 1 = 11, not 2. So we get 11 benefits out of that. So that's why this multiple analgesia, and lot of studies have been done, lot of RCTs and lot of research has been done whether this multiple analgesia is beneficial or not. And it has been found to be beneficial.
Right,
whether
sir.
it is usual technique or paracetamol or NSAID combination, whatever is being done.
Right. Thank you. Can I add something, sir?
Yes, sir.
Yeah. Wonderful explanation given by Dr. Pradeep Jain. Sir, actually there is, if you read the article by Dr. Narendra Rawal, he has been a speaker on a number of forums, and he writes very clearly and in a very, very clearly defined systematic review that multimodal analgesia is much more of rhetoric, but there is disappointing evidence. So I'm sorry, Dr. Pradeep, you are absolutely correct. But the meta-analysis which have come up have shown beneficial analgesic effects when opioids are combined with XYZ, say paracetamol, NSAID, or the gabapentinoid, or pregabalin, or even magnesium, or ketamine, or clonidine, or dexmedetomidine, any one of those. But there is no meta-analysis on combination of different non-opioids. In general, research into the multimodal analgesia has not shown, I repeat, a consistent level of success. And why it has not shown a consistent level of success is because of a large number of variables. You are absolutely correct when we say that 1 + 1 + 1 will not be 3, but rather it may be 5, a synergistic effect. But somehow the evidence is not that much up to the point. So that is one. Though yes, there is a recent review, a systematic review which shows, and a meta-analysis also shows that 24-hour morphine sparing effect of non-opioid as a monotherapy, the 24-hour morphine sparing effect, right, of non-opioid as monotherapy are rather modest. So you see, the point here is that yes, we all are in favor of multimodal analgesia for managing postoperative pain, and this was way back in 1993 by Khaled, from Denmark and all of them. So yes, you're right, additive or synergistic effect, but somehow the evidence is disappointing. That's all I would like.
Article. This is, yes, I know this article by Dr. Rawal that has recently come, and I purposely avoided it writing as a rhetoric. Purposely, because I wanted to focus on the multimodal analgesia.
Yeah.
But
no, your goal is
Indian Society, American Society of Anesthesiology, American Society of Regional Anesthesia, American Society, or everybody is pain management. All the specialists, when they give evidence, it is a high quality evidence. See, the change may be there, it may not, but at present, so postoperative phase is very difficult to judge because so many factors, variability factors are in there in postoperative outcome. Whether it is enteronutrition, balance, electrolyte balance, feeding is there. And the variability factors makes it very difficult to determine exactly what has caused the decrease in morbidity and mortality.
Yeah, so you're right.
Multifactorial problem is there in determining the single isolating agent, whether it is affected or not.
So in short, you're trying to say single agent is not at all effective in the management of pain. Single agent, because all these days we are telling, well, morphine is the gold standard in treatment of pain. With the morphine, now we come to a conclusion that we may be able to effectively block the pain. How do you may be able to achieve something like 85 to 90% of pain? There is still some percent of pain lying untreated. Is that the reason why you want to focus?
So if I can
multiple
actually.
multiple we're going to give one in large, that's going to create complications. So it's better we combine with the drug.
Sir, what you say about single opioid use? We have been using it because I've been doing the post-operative pain services also, and acute pain service. We have the post-operative pain, and if you see, even when we are combining, just like total knee replacement, we are combining opioid, fentanyl, we are combining the paracetamol, we are combining Voveron also. Even the patient feels pain, and lot of patients still complaints of itching and the nausea and vomiting. So what is basically, it is the experience. If you go to the post-operative patient, you see the post-operative patient who has got isolated morphine or fentanyl. In Indian scenario, what I'm talking about, the patient do feel opioid side effects are more prominent in Indian females than male, but it is very, very common.
If I can add, sorry, sir.
The Indian scenario is not.
Sir, can I?
The male scenario is concerned.
Right. So can I add? We simply take the example of only paracetamol and NSAID, right? We forget opioid. Now, the current evidence suggests the advantages of the combination of paracetamol and NSAID are rather modest, right? The benefits of combining other non-opioids are overrated. If you know, it's a nutshell that the benefits of combining other these NSAIDs are overrated, but yes, combination of paracetamol and NSAID like diclofenac are rather modest. So there is evidence and also there is lack of evidence. Both the things are going together.
Both the things.
Yeah, absolutely.
That aspect I agree, because I say is that we are believing on what, even today we are believing on what. Fentanyl appeal, fentanyl is better, fentanyl is something I can die, fentanyl is able to give. Well, after some years, Sufentanil comes. When we are all going towards Sufentanil, well, we don't know whether Sufentanil is working or fentanyl or morphine. So we are in confusion. But we still keep doing all the time. My question is when we use an narcotic or non-narcotic, along with the narcotic or non-narcotic, we are using the local anesthetic also. Because local anesthetic, it's actually entirely different mechanism. Because the drugs, the pharma, is already going to enhance the pain tolerance. That means your pain tolerance is enhanced, elevated. Whereas the other one, the local anesthetic, is going to block the transmission. Do you agree to that?
Yeah. Yes, sir.
Local anesthetic.
Yes, sir. Dr.
Whereas the pharma, they just enhance, increase, elevate the pain response. Am I correct?
Dr. Pradeep, please.
I'm not able to. Actually, the voice is not very clear. It's
sir, if I can just if I can just add, give you one example, sir, you are absolutely correct. Right now, there is a product by the name of HTX011, sir. Product by the name of HTX011, which is actually a combination of bupivacaine plus meloxicam. This is in phase 3 trial going on. It's a fixed dose combination of bupivacaine plus meloxicam. So they have tried to utilize this particular drug. It is undergoing phase 3 trial. You never know that it may come up, when it may come up for post-op pain management. But your concept is absolutely clear, and I'm sure it's very suggestive of that you can combine something, whether I'm taking the example of meloxicam combined with one of the local anesthetic, that is bupivacaine, sir. Yes, sir, please.
And again, putting to Australia, continuous nerve infusion. What is that? Continuous nerve infusion.
Dr. Pradeep, please.
What's continuous?
Continuous perineural infusion, sir. Perineural
infusion. Continuous
perineural
infusion.
Yeah.
Perineural infusion. Then is perineural infusion with what? With a local anesthetic or with a
perineural infusion of local anesthetic.
Local anesthetic. Well, the mechanism is here. The transmission block, I believe. Nothing else. Transmission block. Okay. Impulse transmission block. Is that the one thing you're going to achieve or anything else? Punit. Continuous perineural infusion. What is the mechanism of relief? What is the mechanism of pain relief?
Dr. Puneet, please. Sir, the question has been posed to Dr. Puneet. Am I right?
Yes, yes.
Dr. Puneet, please.
Sir, I couldn't get the question.
Sir, you are telling a continuous perineural infusion.
Yes, sir.
Now, what is the mechanism and how is it going to act?
The mechanism for perineural infusion. Yeah, that's right.
Sir, it helps to maintain the constant concentration of the local anesthetic at that specific site.
That means a barrage of impulse is blocked there. Am I correct?
Yes, sir.
Absolutely, sir. Absolutely. Yeah.
That means we are planning on both ways now. Because we are giving local anesthetic to block the transmission of pain from going up. At the same time, we are increasing the pain threshold. Am I correct?
Yes, sir.
Yeah.
That's what I want to be clear. We are still in the beginning. We are really not sure what is the best treatment in a particular situation. So we're giving all the modalities available to us.
Yes, sir.
So actually, sir, what actually you're talking about is a target specific.
Mechanism based.
Yeah, exactly. Mechanism based and target specific you are talking about.
Target specific.
And somehow, very unfortunately, sir, this perineural and a target specific, has not picked up so well. At least in this part of the world, sir. In this part of the world, am I correct, Dr. Pradeep?
Yes,
Dr.
yes.
Puneet?
People are not using it. What the use should have been there.
That's right.
But with the advancement of ultrasound techniques, it is going to come.
Yeah.
More
that's
so,
right. That's
more so, sir, what we also see is that there is a, the kind of staff that one needs to take care of these
Absolutely.
drugs is of quite a concern.
Yeah.
Yeah.
That's right, sir. Any more questions, comments?
Yeah. Anybody else, please?
Otherwise, I have said one or two comments. Yeah. We, Dr. Pradeep delivered such a nice lecture, of course, everyone. And when he was talking about PCA and all that, there was an attempt a few years back about the iontophoresis and the transdermal PCA came up. The transdermal PCA somehow, or you can say a needle-free PCA. But then, it was even approved, but then it was withdrawn.
There was some drug reaction.
Withdrawn for some technical reasons. But they're again doing a lot of research on that. And you never know, it may come up. It is under further development. So that is something which may re-emerge anytime, sir. That's a very user-friendly transdermal PCA. That's right, sir. Dr. Pradeep, please.
Dr. Ashok Saxena.
Yeah.
We are coming in an era where we have the pain management has to be needle-free.
That's right.
Because
Absolutely.
of so many things.
Absolutely.
So whatever it is, it should be a simple. Like oral is preferred than IV or
that's right.
Then transdermal patches will be the main thing, which are going to stay for the treatment of pain, whether it is acute pain, postoperative pain, chronic pain, whatever may be. So the needle-free technique and one injection technique, like liposomal injection or epidural morphine, these are the things that are going to come.
Yeah, and very nicely, Dr. Pradeep, you talked about one of the sublingual tablet. Unfortunately, in India, this part of the world, we don't have, but at least in Europe, they have this particular sublingual tablet, which has been approved and which contains, Sufentanil, obviously. It's a sublingual tablet, for reducing severe pain following surgeries. Yeah, that's right. It comes by the name of Suvia. DSUVIA.
15 milligram, microgram, milligram.
Microgram. And in fact, there are also, another drug which is undergoing phase 3 trial is Trevina. And that particular Trevina is a novel G protein base. That's a G protein based mu-opioid receptor ligand, which is again in phase 3 trial and more meant for moderate to severe pain. So that's another drug which you never know that another 2, 3 or 5 years may see that picture coming up. Yeah, that's right.
There are many drugs which are available in Europe and other countries which are not available here. Which are very, very, very good use and like transdermal patches. Transdermal patches somehow. Like 5% xylocaine patch, it comes and it goes.
Yeah, that's right.
That's it's a government policy of what they allow.
And another thing which somehow we have been using as an adjunct, and I'm sure you will agree with me, and repeatedly Dr. Narendra Rawal has also emphasized, is on use of complementary and alternative medicine therapies also. In the sense, if someone talks about cognitive behavioral therapy along with that, or say you simple TENS, transcutaneous electric nerve stimulation is such a simple thing, but then only as an adjunct, or mindfulness-based stress reduction techniques. Dr. Rawal is very, very, very much fond of this particular non-pharmacological methods along with pharmacological methods.
See, if you see this American Society of Anesthesia guidelines, they say these are good, but the evidence are lacking.
And not as a sole entity.
The evidences are lacking, though they can be used, they are very good.
Absolutely.
As an adjunctive technique.
Absolutely.
So in the end, we can say that, of course, so many techniques are coming, mechanisms are for pain are being known, various drugs are being known. Sometimes it comes, especially like Dr. Radhakrishnan said, multimodal techniques or analgesia or various things. So only thing is the evidence is lacking. But with experience, maybe, slowly things are emerging. They are far better than when we started this ISSP in 1984, 83. At that time, from now we have so many things in our hand. I remember Professor K. Pandey during the international conference of ISSP in Jamnagar when I conducted it. So in the end, he told me, he was the chief guest of the conference. He said, Dr. Kumar, the time has come that now you should become a complete pain physician. So at that time, I could not understand what he is implicating actually. But then later on, it came. So this stress was, we have to cover every aspect of the patient. Means like psychological. We were giving only nerve blocks as anesthesiologists, but psychological elements we started. We are taking use of physiotherapy. So in fact, in practice, we started use of this various psychological scores regularly in our country. Similarly, help of physiotherapy. It was very regularly we were taking. We were conducting research of that. So in the end, I can say we have gone far ahead, but still, our patient, especially in cancer, they are still suffering. A lot of things have to be treated. There's one thing is well known. There is nothing like a single silver bullet for this pain. So we are coming up with different techniques, different drugs. For that multimodal approach is definitely, we have to go on trying it. Thank you very much. I think
Thank you.
Thank you very much.
Thanks very much indeed. Thanks to all the learned speakers. Thank you, sir. Thank you, Dr. P. Kumar. Thanks, Dr. Radhakrishnan, and thanks, Dr. Jayashree.
Thank you, Dr. Radhakrishnan, for good interaction.
Thank you.
Thank you.
Good day.
Thank you,
Thank
Dr.
you,
Radhakrishnan.
Rakesh, Doctor, sir. Thank you. Dr.
Thank you.
Bye.
Thank you and good night.
Thank you, Dr. Radhakrishnan, Dr. Ashok Saxena.
Thank you, sir.
Yes, signing out, and thank you for the very healthy discussion we had. Well, we look forward to another topic next week, same time. Good night.
Good night, sir. Good night.
Good
Thank
night.
you.
Good night.
Thank you, sir. Good night.